data-driven healthcare improvements. With a strong passion for medical education, she contributed extensively to research, co-editing, and publishing over 35 peer-reviewed articles. Today, she will be speaking to us on quality assurance, strengthening board leadership in safety governance. The floor is yours. The mic is yours, Dr. Sandy.
Thank you very much. And thank you to the Saudi Patient Safety Centre for asking me to speak today. So I have been asked to speak for 40 minutes on leadership, safety, the safety board and governance. And then hopefully we're going to open for questions. And the only other thing I want to say before I start is I want to thank my colleague, Ruth Liley, who I work with. She is the Director of Quality and Assurance at Guy's and St Thomas's, and she helped me collate these slides. Unfortunately, she wasn't able to make the meeting today as she's unwell, but Ruth has over 25 years experience in leading quality and assurance at associate and director level in acute and third sector settings, as well as having had a global quality director role for 2 years. Her current portfolio supports the board and covers quality and compliance, risk management, clinical legal services, including the medical examiner services, complaints and patient safety. So just a thanks to Ruth for helping me get these slides together. So this is the brief. And I hope that I am going to cover each of these through the next slides. So the first one is understanding leadership at the board. And really, I'm going to talk about my own trust, Guy's and St Thomas's. It's one of the busiest trusts in the UK. We're based in London. And one of the reasons that we've chosen to use this as a case study, if you will, is that in 2019, our regulator came, the Care Quality Commission, and gave us outstanding for well-led. So I'm hoping on the basis of our experience, we can share this, and then that'll take us into maybe some questions as we go through the session. So our trust includes St Thomas's Hospital, the Evelina London Children's Hospital and Guy's Hospital, all of which are in central South London. We also have community services in central South London. 3 years ago, we integrated with the Royal Brompton Hospital and Harefield Hospitals, and they are in northwest London. Indeed, Harefield Hospital is about 25 miles away from Guy's and St Thomas's. They're about a mile away from each other. So you can see that we have a very broad remit that crosses organisational structures. So our integrated care structure across London. We work both in the northwest sector and the southeast sector. We provide services to our local communities, and so that includes acute and community services, but we also are a regional and national provider of tertiary and quaternary services, and indeed I would say international, as Royal Brompton and Harefield are internationally renowned. We have just shy of 24,000 staff, an annual turnover of 3 billion, 3 million patient contacts per year, and you can see the breakdown there. And we do provide a full range of hospital services, including cancer, cardiothoracics, women and children's, kidney and orthopedic. So we're talking about structure here, the structure of our leadership, and that is really led by a board of directors. We have executive and non-executive directors led by the trust chair, that's Charles Alexander currently, and they have statutory responsibility and accountability for the performance of the organisation and the quality of care it provides. So what does that mean? Well, it's their role to set the strategy, vision and values, and I'm going to share those with you because they were refreshed in 2024. They oversee the delivery of the strategy and business plans, and they ensure a robust system of internal control. Again, if we drill down on what do I mean by a robust system of internal control? Well, really here, we're talking about governance and oversight. So establishing clear roles, responsibilities, and accountability within the board and management teams. Risk management is an absolutely key role here, identifying, assessing, mitigating risk, particularly financial, operational, clinical, and reputational. There's an important role to play with regards to financial controls, implementing checks and balances to prevent fraud, ensure accurate financial reporting, and that budgets are effectively managed. We've then got regulatory compliance, so adhering to healthcare laws, patient safety standards, accreditation requirements. And then a really big one for our trust is data security and privacy. So protecting patient information, ensuring cybersecurity. So Guy's and St Thomas's were victim to the largest cyber attack in healthcare in the UK in 2024. A malware took out our laboratory services and impeded the quality of care that we were delivering majorly for about 4 to 6 weeks, and then in a more minor way, although still a significant patient safety, because transfusions were really affected for 3 months. So it was a huge issue that occurred that affected the quality of care that we delivered to our patients. Internal and external audits, conducting regular audits to review processes, financials, and compliance adherence. And then something else I'm going to talk about in more detail is performance monitoring. So using KPIs to track hospital efficiency, patient outcomes, and service quality. So we've got a number of committees that we use to support the board, and I think I'm going to talk about that in the next slide. So just to highlight, we have a trust exec that is led by the chief executive, so that's Professor Ian Abbs. And then we've got, and this comprises of leaders of the trust corporate functions. So we've got the chief operating officer, chief financial officer, chief medical officer, chief people officer, chief nursing officer. And then we've also got the bottom 4 pictures are the chief execs of our trust clinical groups. So this is how we've divided up the organization. Again, my next slide will talk to that. Now, the trust executive is accountable to the board for the delivery of the trust's operational and strategic objectives, i.e. the day-to-day business as usual in providing safe and high quality care. They meet together fortnightly in the trust executive committee. But we do have other committees that support different areas of business. I did say I was going to talk about our strategy. This has been refreshed. So our strategy to 2030, it was refreshed last year. Our strapline is better, faster, fairer healthcare. Our values, we did a large staff and patient consultation about what our values are. What are our values? Those that will help us make decisions and really demonstrate the values of the organization. So we're caring, ambitious, inclusive. And then through the strategy, what are our strategic priorities? So a lot of thought went into this. Our strategic priorities include delivering healthcare excellence. I hope I'm going to show you through this presentation how we're doing that for patient safety. Health inequities are huge in our local population, so we really need data-driven improvement. Valuing all our people, so this includes patients, safety, patients, families, carers, and our staff. We know that globally, staffing in healthcare organizations is a big issue. Our financial envelope is essentially static. So as our strapline says, we have to deliver better, faster, fairer healthcare for all. And how are we going to do that? We can only do that by innovating our pathways, our processes. It may include digital innovation. It may be just getting rid of the waste and really thinking carefully about having leaner pathways and processes. And then modernizing our infrastructure, absolutely key. The organization has really put its money where its mouth is. And 15 months ago, we had the implementation of EPIC, which is an electronic patient record. That is tens of millions that they have invested to increase productivity and improve outcomes for patients. Sorry, just let me move the next slide. So I said I would talk in more depth about our corporate governance. So you can see from this schema, we have the Council of Governors in grey at the top, and the Council of Governors in an NHS trust plays a crucial role in ensuring that the trust operates in the best interests of patients, staff, and the wider community. So their roles or responsibilities include holding the board to account. So the governors provide oversight and challenge to the board of directors, ensuring the trust is well managed and adheres to its values. Representing members and the public, so governors are elected from staff, patients, and the public, acting as a voice for their concerns, interests, and priorities. Appointing and removing key leaders. This includes the chair and non-executive directors. So according to NHS guidelines, no director, no non-executive director should be in role for more than 9 years from their first appointment, and the Council of Governors is key to ensuring that. Approving key decisions. So the council must approve significant transactions, mergers, and changes to the trust's constitution. They receive the annual report and accounts and review and input into the trust's financial and strategic performance. And they really support engagement with the local community. They help by building relationships between the trust, the wider community, and promoting transparency and trust. So what it doesn't do is manage the daily operations of the trust, but rather acts as a key link between the trust and its stakeholders, ensuring governance and accountability. We then go to the board of directors, which we've already discussed, and then board committees. So these are committees that are supporting and delivering assurance to the board of directors. So you can see here, the one that I'm most involved with is quality and performance. We've also got people, culture and education, a major transformation program, the finance, commercial and investment, audit and risk, senior leadership, talent, appointment and remuneration, and then the academic group. Now, each of these is chaired by a non-executive. All of the names underneath are non-execs that chair these committees. We then have the primary executive committees of the organisation. So again, we've already mentioned the Trust Executive Committee. They meet fortnightly. We've got the Trust Ops Board, chaired, so the Trust Executive Committee is chaired by Ian Abbs. The Trust Operational Board is chaired by John Finley, who is our Chief Operating Officer. We have the Trust Risk and Assurance Committee. Again, that's the one that I'm most familiar with, and that's chaired by Simon Steddon, who's our Chief Medical Officer. And then we've got Investment Portfolio, which is chaired by our Chief Financial Officer. Then we have the structure in which the organization is built. So those are the corporate functions, if you like. And then we have our clinical or delivery groups. So cancer and surgery clinical group, Evelina, and which is Evelina London and women's and children's clinical group, heart, lung and critical care, integrated specialist services. And then we've got a delivery group, which is Essentia. So Essentia really deals with the infrastructure of the organization, the buildings, the transport, etc. And it's really through the balance of clinical group delegation and our executive committees that we're providing, as our chief exec would say, assurance to the directors rather than reassurance. And I'm going to talk about that later. So we have the trust, we've got the corporate functions, and then the actual organization is divided up into 4 clinical groups that we've already outlined. Now, the responsibility is set out in the scheme of delegation to the organization, so that we have autonomy. The clinical groups have autonomy to design the governance they need to discharge the responsibilities. All our clinical groups have executive committees and then supporting committees. And each group has a chief of staff, and this is a fairly recent change for the organisation, coming about in the last couple of years, that has responsibility for governance. So each of them, we have 4 chief of staffs for each of the clinical group, and then 1 corporate chief of staff. And here you can see a schema of our operating model. So this is the trust operating model. We've got the 4 clinical groups and Essentia, which is the delivery group, and they oversee a number of directorates. So you can see that, for example, Evelina London Women's and Children's Clinical Group has 5 directorates within it. Integrated and specialist medicine is by far our largest clinical group. It is probably the one that carries the most risk across the organisation, as it has acute and general medicine, emergency care, it has radiology, it has pharmacy, and then integrated local services, which is essentially community services. Responsibility for operational service delivery and for the delivery of trust strategy falls within the remit of the execs of each of these clinical groups, that is then delegated to the directorates. And they are supported by a range of corporate services, including finance, HR, IT, and the directorate I work within, which is quality and assurance. So really, this is a deeper dive into the guiding principles, if you like, of our trust operating model. So I'm not going to read each of these out, but I'll just highlight some of them. Although we are a big organisation and we have delegated authority to the clinical group structure, we are a unified organisation. And so that really applies to points 2, 7 and 8. So we are unified, we will not fragment or lose the unity of the overriding trust. That means that all staff in the organisation can benefit from the opportunities afforded by being in such a big organisation, be that through training, education, career progression. And then, of course, the running costs of the organisation should be leaner, and there will be economies of scale that we can enjoy. Along with that, we have clear lines of accountability. clear lines of sight with regards to the accountability for functions and services. However, we've already mentioned that our clinical groups do have some flexibility within the trust-wide framework of how they deliver strategic governance, policy, and systems. So in addition, I think a really important part of the organisation is clinical leadership. We do have a significant amount of clinical leadership at exec level. Our chief exec, Ian Abbs, is a nephrologist. 2 out of 4 of the clinical group chief execs are clinicians. But more importantly, I would say, I'll just go to this slide. I think my slides went a little bit out of order. We have a number of we have about 30 quality and safety committees across the organisation that are led by clinicians. So these are generally senior consultants. They can sometimes be senior nurses. And you can see here we've got the Clinical Ethics Advisory Group, Drugs and Therapeutics Committee, Health and Safety. We've got the Guidelines Group, the Acutely Ill Patient Group, and each of these report in either to Patient Safety Committee and or the Trust Risk and Assurance Committee. We then have joint working between the clinical and delivery groups. You can see here it's a two-way conversation. However, we do have a line of reporting that goes all the way to the Trust Executive Committee and to Quality and Performance Committee. So give me 1 second. There we go. Oops, nope. Sorry, it's going the wrong way. So, okay. And I think another really key point with regards to how the organization is reviewed, how do the execs get assurance on clinical group performance? So that is one of the key roles of the that we talked about with regards to having robust systems of internal control. So how do our board of directors, how are they able to seek that assurance? And they're able to do this from the exec to exec performance review meeting. So the clinical group execs will meet with the corporate execs every quarter, and their performance is assessed. We base it on what we call the assurance scorecard, and what you can see in this slide is that here, this is an example assurance scorecard, and we have used the domains that we are regulated under by our regulator, the Care Quality Commission. So when the Care Quality Commission come into a healthcare organisation, they are looking to see, is it well led? Is it safe? Is it caring? Is it effective, responsive? Are there good use of resources? And so from board to ward, we are looking at these domains. So prior to meeting, the clinical group performs a self-assessment against the scorecard, including a commentary and rationale. There's a lot of paperwork and data that are presented. The execs obviously read the paperwork, and then during the meeting, the meetings generally run, I think it's about 3 hours. The trust exec and the clinical group execs discuss issues, risks, and actions that need to be taken. And then following the meeting, the scorecard is finalised by the trust chief executive, calibrating across other clinical groups. So importantly, we do all the clinical group PRMs within about 10 days. It's quite a heavy week and a half every quarter, but it does allow for calibration, and the meetings allow for a constructive challenge and support through honest and open dialogue. So we've talked about corporate governance, but there is also the structures in place around clinical governance, which is integrated into the corporate governance framework. You know, one of the things we found with the group model is that there is an increased distance between the ward and the board, and we need to be assured that risk management systems are operating effectively and that collectively risks are being managed and escalated when they need to be, from the ward through specialties directorates, clinical groups, into our executive committees. So moving on to tools and strategies for board members, I said I would talk about assurance. I do think it is important just to understand the difference between assurance, which is an objective examination of evidence for the purpose of providing independent assessment on governance, risk management and control process for the organisation, and reassurance, which is somebody saying that everything's fine. And what we are seeking is objective data, evidence that assures the board that we are on track and that as a performer, as an organisation, we are performing well. So one of the things that we've brought into play that has been really helpful in the last couple of years is the board assurance framework. So the board assurance framework contains risks that threaten the achievement of the trust strategic aims and objectives, along with information on existing and planned controls and assurances that these strategic risks are being managed effectively. Okay. This is an example of what our board assurance framework looks like. We've got 4 tiers of assurance that go from tier 1, which is those day-to-day risk, the way that risks are managed day-to-day, and assurance comes directly from those responsible for delivering specific objectives or processes, and that's really at a service or departmental level, all the way to tier 4, which is when we're gaining assurance from external or independent bodies such as external auditors or regulatory organisations. We then have 4 levels of assurance that go from no assurance, so nil, to full, and obviously we're aiming for full, and sometimes we get there. A lot of the time we are stuck on limited and substantial. These are some of the examples of those strategic risks. So risks that are going to affect our strategy. We talked about our strategic intent earlier. So operational performance, quality of care, our estates. So in the UK, you know, a lot of our estates are old. Guy's and St Thomas's is 900 years old. Our buildings aren't quite that old, but they are fairly old in places. Workforce recruitment and retention is key. You know, we've spent tens of millions on an electronic health record called Epic. What are the benefits that we are realizing from that infrastructure investment? I think another strategy is really to think about what your framework is for dealing with patient safety incidents. So for 20 years in the UK, we had the Serious Incident Framework. Just over a year ago, this changed with the publication of the Patient Safety Strategy and the framework that went with that. So that's our Patient Safety Incident Response Framework. This is a game changer. This framework allows us to focus on systems and a just culture, really focusing on learning and improvement. So, you know, key aims include compassionate engagement of all of those affected by a patient safety event, such as patients, families, carers, and staff. That we apply a systems-based approach. So we use the systems engineering for improving patient safety framework. that our responses are proportionate. So it is now not that we have to do the same root cause investigation for every patient safety incident that leads to moderate harm or above. We are allowed to review the incident, assess what those contributory factors are. If we already have identified those contributory factors, then we can focus on improving that rather than keep doing an investigation where we know what the outcome will be. I mentioned the SEEP, so the Systems Engineering for Improving Patient Safety framework. One of the tools that we use that applies the SEEPS model is the after action review. I'm sure many of you are familiar with this. It's used throughout the it's used, but it came from the American military, and can be used when things go well and not so well. But it's really a 2x2 matrix, you know, that asks 4 questions: what was supposed to happen, what actually happened, why was there a difference, and what can we learn from this? And then, you know, our regular, so NHS England describes never events. So these are really patient safety incidents that they deem as being wholly preventable. Where guidance or safety recommendations that provide a strong systemic protective barrier are available at the national level, and they should have been implemented by healthcare providers. However, I think you'll see from the list, these are things that continue to happen again and again. Now, with our never events, we have been challenged by our board to not be complacent and to really be thinking about what those systems and processes are. And we've completely changed the way that we review when a never event occurs, the sorts of investigations we do, and actually looking at all those never events in a thematic review has been very helpful, and it has been highly regarded by our directors. Another thing I'd ask you from a board level is, what is your patient safety culture? As a board member, do you have a real feeling of the safety climate within your organization? If you don't, have they done a survey? Could you do a survey? In preparation for the new patient safety framework, we did our first safety culture survey at Guy's and St Thomas's. There are a number of validated tools that you can use. We happen to use the safety attitudes questionnaire and modified it slightly. And you can see that we got a fairly good snapshot of our safety climate. So we had over 1,000 respondents, which is around 5% of the workforce. And you can see that there are some dimensions where we did have a very positive outcome. So colleagues in the organization were positive about the organizational structure, and the openness in the organization, and recognition of stress, and provision of safe and evidence-based practice. However, you can also see there's some areas that we really need to work on, particularly around blame and shame, job satisfaction, and working conditions, availability of resources. And that very much aligns with recent literature. So there was a paper published about 18 months ago in BMJ Open, which showed that the biggest predictor of a decrease in safety culture metrics was staff feeling overworked and stressed. And I think that is demonstrated in our findings as well. In the NHS, we also have the annual NHS staff survey. This is a national survey which can provide a level of benchmarking for each organisation, especially from that safety culture climate perspective. So these are some of the questions that all staff ask, and that benchmarking across different organisations is particularly helpful. And then I've already mentioned quality improvement, absolutely key. Again, you know, as a board member, is quality improvement something that you're talking about at board? Is it something that your organization has, you know, capability to deliver? There does need to be some training. What training is available for staff to really deliver on improvements, because it's they that know what doesn't work and what could be put in place, and also obviously involving patients as well. So finally, challenges in board engagement with patient safety. And I think that there are a number of challenges that you're probably all aware of, but, you know, some that I might highlight include that, you know, competing priorities. So we'll all know that boards oversee financial, operational, strategic, and compliance, and often leave patient safety as just one of many concerns. On boards, there's often limited clinical expertise. Many board members might come from business or financial or even legal backgrounds and lack that clinical knowledge. Data overload. There's a plethora of data and ineffective reporting. How do you find out what you need to know? The healthcare is incredibly hierarchical, and that may prevent open discussion about safety concerns. Lack of patient and staff engagement at the board, and inconsistent leadership commitments. And I think oftentimes board members are finding that they're ending up being proactive. I mean, particularly for us, we've had so many issues in the last few years, from COVID to an IT outage to a cyber attack. That's literally happened in our trust over the last 3 or 4 years. That it is hard for the board to be focusing on being proactive when there's so many things to react to. But how can you improve it? So, I mean, making patient safety a standing agenda item. When we do our performance review meetings, the first domain that is talked about is patient safety. The second is caring, and generally the last is financial, unless there are some big issues. But that's how our board do it. And I think that then spills through into the organization. I think that having really thinking about your metrics and having good governance over safety metrics is clear, and understanding what they are. One thing that, again, we found very helpful at our board rounds is having a patient story at the beginning of the board round. So that can either be a recording or a patient coming, and sometimes having staff come and talk about their experience. So we had a very powerful session from our quality and assurance team. We have 2 colleagues who do all the patient safety investigations, and under the new framework, patient, family and care involvement is key, and they talked about their experience of bringing patients and involving patients in patient safety experiences, which was really powerful. And then just ensuring that the board is trained. If there are knowledge gaps, being humble, admitting that, and getting the training that you need. And ensuring executive accountability for safety initiatives throughout the organisation. So finally, I mean, to finish with, understanding that all board members are equally accountable for each of the domains. It is not just the jurisdiction of the Chief Financial Officer to focus on money. That is equally the role and responsibility of the Chief Medical Officer and the Chief Nurse, and vice versa. Having an appropriate level of knowledge, skills and understanding to be confident, and this allows them for that constructive challenge, for that open dialogue that can support delivery. Be curious, be consistent. You know, board leadership and having a consistent board leadership is really important to organizations, and being visible. So going on walkabout, many of our execs are seen in clinical areas, talking to our clinical staff, operational staff, and patients, and really seeing at first hand what's happening in the organization. Okay, so I think that is 40 minutes. I'm sorry I kept looking at my watch, but I hope that that's been helpful, that we've given you an overview as to proactive, data-driven, effective governance that is culture-focused and a way to drive forward patient safety. So I'm going to stop there. I'm going to stop sharing.
Thank you very much, Dr. Sandy. That was very informative, great presentation. We have some questions in the QI. Let me start with the first question. What criteria does the Investment and Portfolios Board, IPB, use to evaluate potential investor or investments or projects? Do you want me to repeat that? Dr. Sandy? Hello?
Sorry, I was on mute. Sorry, would you mind repeating that, please, Dr.
Yes,
Aram?
actually, in brief, what criteria does the Investment and Portfolio Board use to evaluate potential investment or the project? What are the criteria to evaluate, potential investment or projects?
I mean, I'll be honest, I'm
Yes.
not quite sure what criteria they use. I know what criteria I think they should use.
Yes.
And that and that
that's
really
fair
would.
enough.
Yeah, and that would really be around quality metrics. So, there's no reason for them to not use the domains of our regulator. How will it increase the quality of care we're delivering, the efficiency of care? Is it a good use of resources, etc.? But as to the exact criteria that they use, I'm sorry, I don't know that.
That's wonderful. Another question. How does the Trust Risk and Assurance Committee approach risk management? And what recent risk you have already shared with us, a recent risk that have been identified? And I think I saw them in one of your slides, and it's very interesting.
Yeah, so the Trust Risk and Assurance Committee
Yes.
is a really good committee. We have a lot of discussion there. The BAF, so the Board Assurance Framework, is presented every month. So that committee meets every month, and the Board Assurance Framework is presented every month. So risks change all the time, and I think what's been really useful to work with the board with is the risk appetite of the board. So we've got the current risk. For example, one of the big risks in our organization is admin safety. So that is currently scoring at 20. So that's the current score. When the board look at the Board Assurance Framework, they want the risk to be about 6. So how are we going to reduce the risk from 20 to 6? And just seeing that visually, seeing that what the current risk is and what the board want it to be, so they don't have an appetite for that risk. They want to reduce the risk involved in admin safety, has been really helpful. But again, that's something we've only brought in the last 12 months. So I think our approach to risk is maturing. When we, that happens at the Trust Risk and Assurance Committee, when we talk in the performance review meeting, so with our clinical group executives, what we want to see is that they have clearly articulated the top 5 strategic risks to their clinical group. They put in what the controls and mitigations are, and then there is a conversation about what further resource they need to decrease that risk. And that is where we're aiming for. Some of our clinical groups have got there, some not so much, but that's a very mature approach where the risk to the organisation, the risk to the department, to the ward, to the directorate underpins the narrative and then the request for resource.
That's wonderful. Adding to that, the risk you have mentioned in the presentation about, staffing feeling overworked and stressed. And
Yes.
in the risk, I have noticed also, and seems to be, it's very common here and everywhere after the COVID, and, putting risk as in risk the workforce. Can
Yes.
you elaborate on some of the strategies you took in the workforce risk, healthcare workforce risk?
Yeah, so that would be led by, well, it's primarily led by our chief people officer and the people team. However, the chief nurse's office has really focused on nursing and midwifery. We've had a number of national inquiries into maternity services, and now we have very direct recommendations nationally about what staffing ratios should be. So I think that, and then the chief medical officer as well. So to your point, what have we done about it? Well, I think we focused on well-being. Okay, that was something that was, I worked as a doctor in the NHS for 20 years before anybody started talking about well-being. So what does that mean? Well, that means flexible working. It means having hot meals. It means having somewhere to put your stuff. So that's well-being. We've also focused on stay and grow. So and I mentioned this already, across the organisation, what are the training opportunities, the educational opportunities, the opportunities for career progression? Another really important thing, thinking about the diversity of people that are working within our healthcare organisation, is that we've got to have equality, diversity and inclusion. It's really important. It's one of our values. Yes. That we've got to be inclusive. And there were some staff groups that didn't get promoted. Let's be honest, if you are of Black ethnicity, there were really big barriers to promotion. And our senior nursing leadership did not look like the rest of the nurses working in the organisation at one point. They looked different. So there's been a real focus on anti-racism, equality and diversity, and I think that's a really good thing. So I think those are some of the strategies. The chief medical officer is really focused on ensuring that consultants are able to develop, and this is coming from Health Education England, developing a portfolio so that that's the way to prevent burnout. So what could your portfolio be in? It could be education, management, leadership, improvement, AI, digital healthcare. I mean, there's a plethora now of opportunities that didn't used to be there 20 years ago. But that's a really a big push from our chief medical officer, and obviously patient safety and quality. And that's what I've been tasked with. So I have developed education courses and then linking those into career opportunities. I showed you the slide of all the trust committees that we have in quality and safety. They are clinically led. So you learn and then you're able to apply that knowledge within the organisation.
Wonderful. Well said. And, it brings us to the other question. In your experience, what was the biggest challenge in implementing such a framework, bringing patient safety on that level, on the board level? What would you, put? You have already mentioned some of the challenges, but what do you think the biggest challenge that really faced you?
I think
especially getting the board members active in patient safety.
Yeah, so I think we were talking earlier on about sustainability. So you have a regulator. Okay.
Yes.
And I think one of the things is ensuring that the way that from the ward is assessed is the same way that the department's assessed, is the same criteria we use for directorates and then the clinical group. So using those there's 6 domains for our regulator for well-led, safe, caring, financial, etc., is very helpful, and it's standardized it across the organization. So that means that at the board level, they are actually having the same conversations that they're having. It's amazing. The same conversations that are being had at board level as are being had in departments or at clinical group level. And so I think that has been very helpful, that the assurance scorecard just allowed for clarity. But it's really, what's really hard is the clinical groups always want to be fully assured in every domain. And that is challenging for our executives when they don't have that level of assurance. And I think one of the other things that I think of role modeling how important quality is, and I mentioned it, is it is the first thing that is talked about at our performance review meetings. It's not finance. It is quality and then caring. And I don't know, I think that speaks volumes. So how that was done, I think, was from being very structured about how we are assessing performance through the organization, and then having clinical leaders throughout the organization who were able to take that information and then present it with quality and safety being the most important domain.
Great. Thank you very much. We're gonna see there's no more questions in QI. I see some raised hands. Ms. Hiba, is anybody wants to ask question? I see some couple of raised hands. Thank you, Mona. Okay, so we'll have one more last question, Dr. Sidney. In regards, how can healthcare boards create a governance structure that balance safety, efficiency, and sustainability? You already mentioned, about sustainability, but in just a few words and summary, how do you think we can create that structure with this balance?
I think maybe setting out the domains that you want to focus on. So if you did have a table, a scorecard, I think if you clarify what the criteria are under each of those. So under the scorecard, we have what the criteria is for a fully assured, limited assurance, no assurance, and having that objective measure for each of the criteria. That is helpful. It does come back to the definition of assurance. It needs to be objective as possible, and then if you have sustainability underpinning all of that, because it has to. So are you financially sustainable? Are you responsive and sustainable in effectiveness? I think sustainability underpins all of those domains.
That's absolutely. We have one raised hand here, Mr. Yusuf Hanif. Mr. Yusuf. Okay, let me check another one with raised hand with a question. Sujata Nepali, Sujata, do you have any question? Well, if he's muted, Hiba, can we unmute? Okay. So we have a couple of minutes. I think we couldn't get those questions. Cindy, this has been very, very informative, really session. We learned a lot, especially that, you know, in a lot of places, healthcare is going through huge transformation. And it's very interesting that, you know, to hear about the trust and in England and that integration that you presented with the structure, with the governors, that is very interesting in pushing patient safety, and it's very related to patient experience, quality. It's all, as we discussed previously, it's all interrelated. We are in the stage also of, like, you know, especially with the patient safety center and with the clusters that and the transformation that's going in Saudi Arabia. You know, this is of a high priority. And maybe in our strategies, I've noticed that, you know, for us in the Ministry of Health and in transformation, probably the access to care, of course, innovation is being, you know, maybe different is the access of care. Probably, I wonder, probably in England it's different, but it is a priority in our transformational initiative. And all what you have mentioned in this strategy in terms of the integration, in terms of innovation, and, you know, very interesting, very, very aligned to what we are doing here in Saudi Arabia. I really enjoyed really moderating this session. I really learned and enjoyed hearing from you, and with this experience of the governors and bringing patient safety to this level. Thank you very much for the time. And on behalf of Patient Safety Center, I would like, you know, to extend my thanks to all the attendants and to Dr. Sidney for all the time, experience, sharing all this wealthy information. Thank you very much. And we look forward to seeing you again. And hopefully we see you in person here.
Thank you. Thank you very much for letting me speak today. Nice to meet you all. Bye.
Bye, everyone. Thank you very much.